what I'm going to do, as Beverly said, that I will cover some of those areas. And I know that you probably know a lot about this already, but so do excuse me if I'm going through some very basics, but I just want to make sure that we are talking sort of from the same language. And some of what I'm going to tell you today may be different from what you may have heard in the past, and I'll be happy to discuss with you why some of my views may be different and what they're based on. First of all, what is psychosis? Psychosis essentially is really not a disease in itself, it's a condition of the mind. A condition of the mind where there is a significant break with reality as we know from day to day. And realities are really different for different people, but there is some constancy in our reality. Today's reality is very similar to yesterday's and tomorrow's. When there is a total break in that, in a sense, that's what basically psychosis is. And as a result, the person has difficulty in meeting day-to-day demands. So when do we know someone has psychosis from a psychiatric perspective? Essentially, I think one of the reasons psychosis is regarded as one of the most serious mental conditions because it pretty well affects every basic fundamental human function. Thinking, feeling, behaving. These symptoms, I'll go into a bit more detail in a minute. These symptoms may change from they may be different from person to person in terms of their content, but the form is essentially the same. The content may be different from one culture to another, but the form is more or less the same. And they may change over time. What I am going to do is sort of describe to you very briefly how we group these symptoms that are generally considered as what we call positive symptoms of psychosis. They're not called positive because there's anything positive about them. They are positive because they are abnormal experiences that normally should not be there, as opposed to negative, which is absence of things that I'll describe in a minute. So delusions are one form of psychotic symptoms, and delusions basically are firmly held beliefs that do not tie in with what the person's environment basically believes. So what may be a delusion here may not be a delusion in some part of Africa, because that belief would be shared by everybody else. What may be a delusion to an atheist may not be a delusion necessarily to a very, let's say, some small, particularly fundamental religious denomination. But that does not, because the belief would be shared by others as well, and it would be consistent over time. Logical minds don't just will not change that particular belief if it is a delusion. To the person, it feels 100% true because that is so there's no point arguing with the person who may be experiencing delusions. You cannot argue them out of it. That's not entirely true to this extent that I'll mention a bit later on. The sort of work that we've been doing, which is really early intervention and secondary prevention, if you do catch people early on when the delusions are still beginning to form, you can work with them and get them to see the logic that doesn't fit into their beliefs. The examples would be that the person may believe somebody is going to harm them, or they may have delusions that they have special powers, but they will act on those, and that's what makes delusions dangerous. The different examples of delusions that we see commonly are persecution, grandiosity, bodily delusions when they believe that there is something wrong with their body or a device has been implanted, religious delusions, delusions of reference, which basically means that the events around them, including, say, there's two people talking on the television, the person would start believing that they are actually talking about them because they make it a reference maybe to the color of the shirt the person was wearing the day before, something as minimal as that, to which then they attach a salience that is beyond any kind of reasonable explanation. Or they may have delusions of mind reading. Sometimes, not often, but in very acutely ill patients, we do see sometimes the person may actually believe that they're completely under control of an outside force. And these days, we see a lot of it in relation to social media, computers. When I was training in psychiatry in England, the most common delusions that were about the Russians, because that was the height of the Cold War. And anybody who had any persecuted delusions, they were somehow connected with the Soviet Union and so on. Then it changed over time, and now it's mostly about social media, internet, computers. So the form remains the same, which is essentially it's an abnormal belief that is not supported by evidence, as everybody else sees it, but the content will change over time depending on the circumstances, depending on what we are experiencing. It's a bit like when a writer writes fiction, they can only write from what they either experience or what they imagined, and imagination can only go so far of what you have actually experienced or read about. Then we have hallucinations, which is also a core feature of psychosis. And delusions are disorders of content of thinking. Hallucinations are disorders of perception. And they are disorders of perception in terms of the form of perception. So you have the person has a perception of something being there, either seeing or hearing or smelling, but that thing is not actually there. So without the object being present, the person perceives that object. The most common ones we would see in young patients we see with psychosis would be auditory hallucinations, that when they hear voices, sometimes one, sometimes two, sometimes many, hundreds. So you can imagine how disturbing it can be and how distracting it would be that a person would not be able to pay any attention to what they are doing. About 30%, 25-30% of people will report visual hallucinations. But if we only see visual hallucinations, and if that's the case, if I were the patient, I would ask the doctor to make sure that you do an EEG and you do a thorough investigation, because visual hallucinations can sometimes represent certain types of epilepsy. So that's why when you mentioned, Beverly, that I used to run the PEP program, which still exists. I'm still involved. I just gave up my administrative role there because of this youth mental health project. We do thorough investigations on everybody at least one time. I know some people think we're wasting money. I don't think we are. We do a CT scan on every young person. We pick up about one tumor a year. I still think it's worth the money to pick up that one tumor a year, or something inside the brain that is physically wrong, so that we're not treating the wrong thing. It's the same way we do thyroid tests on everybody, because thyroid conditions can also present them sometimes. Then there is the third domain of psychotic symptoms, what are disorganizations of thought. So delusions are disorders of content of thinking, and this is now the form of thinking, in the manner in which thoughts are put together. This would range from something relatively mild, like the person starts a conversation, then wears off something else, and then somewhere else, and somewhere, and you really have to bring the person back to where they started, to completely, totally jumbled conversation, which makes no sense at all. One word has no connection with the other. Often this disorganization of thinking, there's nothing wrong with it. It's the structure that they are putting together to express a thought, because it's not the language that's the problem, it's the thought that's the problem. If you think for a minute, if you're talking or thinking about something, it may be very different from what you were doing 2 minutes ago, but you would be able to go back and trace how you reached that. Whereas when someone has really disordered thinking, you cannot make any connection, and you cannot even bring them back to where did you start? How did you get to, I asked you about how was this morning, how did you get to talking about how the Kellogg's Corporation is run? But you can actually sometimes see the connection. They started with breakfast, with Kellogg's, and this is a real story I'm telling you about a patient who once, he started just the first 2 words about breakfast, and then he gave me a lecture on how the Kellogg's Corporation was being run, and even that was very disorganized. Then we have negative symptoms. These are very important, but sometimes very hard to get your grip around, because they can be sometimes assumed as, oh, this is just laziness, or the person is just being difficult. There are essentially five negative symptoms. Half of them are disorders of difficulty in expressing emotion. So the affect doesn't change much. I see mostly, for many years, for the last 20 years, I've mostly seen and treated young people at very early stages. We don't see a lot of this at the beginning, especially the affect being flat. Over time, it becomes more and more common. Or there's not the affective responsivity. Say, we're talking about an emotional issue, you just don't get that rise out of the person. And the same way, there's the expression of thought. We're not talking about the content of thinking, we're not talking about the construction of thinking, we're talking about just simply there not being enough thoughts. What we'd call poverty of thoughts, what the medical term is elogia. This basically, the thoughts are coming very, very slowly, and sometimes patients will describe, my mind is completely empty. I don't have any thoughts, which is very unlikely. When you think about normally, we always are thinking about something, or we're thinking about thinking. Then there is the disorders of expression. This is the disorders of expression, then the disorder of behavior, of motivation. And that's much, much more common, like social withdrawal, emotional withdrawal, not being interested in any activity. If you think about, when we get up in the morning, we have certain variations. Some people get up quickly and get going, and some people take a bit of time. But we have, human beings, we have a basic volition to do things, to get engaged in activities, to whether it is to go to work or to make coffee in the morning, but it comes naturally. And that is what is missing sometimes. And about 25% of people with psychosis at the beginning will have negative symptoms that are persistent. Another 15% will have negative symptoms that are very transitory and they go away. But if people have had several episodes, then you get about 40% have persistent negative symptoms. So they do accumulate over time, partly because of environmental understimulation, because let's face it, our patients don't get the best care, they don't get the best environmental stimulation, they're not going to work, they're not able to get jobs. I mean, if those of us all of us have worked at some point, I mean, so many hours of the day we spend at work, and there's a lot of environmental stimulation. We socialize at work, we talk to people, and when that's not present, that feeds into negative symptoms that are already present and only makes them worse. Okay, so I will skip that. Sometimes people will also report certain changes in their feelings. What some people would call mood swings. They're not really mood swings, but there's kind of unpredictable changes in feelings. Or the emotions may generally be dampened, and then suddenly there might be an outburst. 50% of people who develop psychosis would have gone through a period of depression at some point earlier in their lives. However, if you saw the person at the time, there's no way of knowing who out of these people who have depression are going to develop a psychosis. But there is generally people who develop psychosis have gone through multiple episodes of different types of mental symptoms, anxiety, depression, periods of social withdrawal, and so on. Okay, let me just... the last aspect of psychosis that's very important to know is the what we call cognitive functions, and these are basically our brain functions that make us intellectually and otherwise function with our environment. For example, information processing. Any information that comes through our head, we process it. We don't just, it doesn't just automatically register. We also leave out certain things. For example, if you're listening to my lecture and suddenly you hear a noise, you will hear the noise, but you may make a decision that you're not going to pay attention to that, or you're not going to pay attention to me if the noise is much nicer than what I'm saying. So there is a conscious process, there's a larger unconscious process. So this information processing is important for psychosis, because one of the problems in psychosis, especially in the early stages, is that there is a loss of this filter. So essentially the brain gets bombarded with all kinds of stimuli. One of the things we tell families after a person is recovering from psychosis is just don't expose the person to too much stimulation at the same time. If you're going for a walk, at least for the first few weeks, don't go straight into a busy mall, because there will be an information overload. The person's brain hasn't yet recovered enough to be able to filter all that information and only take what the person can cope with. Memory is probably the most important part, and it's not the kind of memory, it's not that people forget everything, but it is relatively sophisticated aspects of verbal memory, which is being able to remember what you may have learned half an hour ago that you may have to use again. Or working memory, which is something like, you want to go to a restaurant, you look up a phone number to call, you look at the phone number, you turn your head, you call, and then you don't have to remember that phone number again. So that's working memory, whereas verbal memory is you have to retain it for a bit longer. So if you're going back to school, let's say after psychosis, you are going to need your verbal memory, because you have to learn new material. And new material means it comes in, not all of it is going to register, but some of it should register and some of it should be retained. So verbal memory is also important for many other reasons. I'll get into that hopefully later on. And then there's executive functions, because human brain, unlike any other brain, performs a number of executive functions, which is primarily the job of the cortex and the frontal cortex. And these are much more sophisticated functioning. For example, you're faced with a situation that might be stressful. You might be able to anticipate a little bit that this is going to be stressful, or you might not. However, the way you react to that each time is not going to be that you'll have to sort of call your mother and say, how do I deal with this? A learning takes place, and then you have a planning process. And a lot of it is unconscious, that you plan for something, how you're going to deal with it. And from that, you have learned, and a similar situation arises, you apply what worked the last time. Problem solving, which we do all the time, every day we solve problems, and dealing with new situations. And that is why people who are prone to psychosis, or people who have psychosis, are highly sensitive to stress, because they are not able to very quickly solve problems. They are not able to deal with new situations as quickly. I said at the beginning that psychosis is not a disease. Psychosis is what we call a syndrome. It's all of these symptoms that I mentioned. Not all of them have to be present. You can have only delusions, you can have only hallucinations, you can have only thought disorder, or you can have all three of them. But in order to meet a criteria for being treated, it has to be at a threshold that it's beginning to affect your functioning. Otherwise, 15% of the general population hears voices, but most of them don't have an illness. They're quite able to function perfectly well, because it doesn't affect their functioning. It's just part of their perception. That's how their brains work. Psychosis is not schizophrenia, but everybody who we would regard as schizophrenia has a psychotic disorder. There are other conditions where from time to time people may have psychotic symptoms, such as major depression, bipolar disorder, even people who have severe anxiety disorders may from time to time, under extreme stress, have some psychotic symptoms. That doesn't mean they have a psychotic disorder. People with post-traumatic stress disorder often will have psychotic symptoms, but they are generally self-contained and they go away as soon as the stressful situation disappears. So that's just so some facts. In textbooks, it still says 1% of the population has a lifetime risk. It's really much, much higher than that. It's closer to 3% have a lifetime risk. In other words, at birth, the risk of having a psychotic disorder is about 3 in 100. That's not very common, but it's not that uncommon either. The important thing is that most cases appear before the age of 25. Pretty well 90% of cases appear before the age of 30 to 35, very rarely before 14. From 14 to 18, about 25% of cases would appear in that age period. So it is primarily an illness of young people, as are all mental disorders. 70% of all mental disorders appear for the first time between the age of 11 to 25. And that makes it even more important that we really pay attention, because they are the future of our society. And in Canada, 3% of our GDP is lost because of youth mental health problems. And it amounts to about $55 billion. We have something like less than 6% of the budget actually goes to mental health. It should be somewhere around 15%. So when you look at only psychosis, and if you look at only schizophrenia spectrum psychosis, the incidence is actually much higher than what was believed. We did a study a few years ago here on the island of Montreal, and we found in the age group of 14 to 25, the incidence means number of new cases per year per unit of population. So if you have a population of 100,000, you expect about 33 people in 1 year. However, it's going to vary according to socioeconomic conditions, geography. If there is more material deprivation, social deprivation, you'll have much higher number of cases. If there is less social material deprivation, you'll have less cases. But as I said earlier, most people would have gone through a period of other psychiatric symptoms, and hence that there is really need for intervention even before psychosis appears. And this is basically the trajectory. You have majority of people with psychosis, during childhood, you wouldn't pick up much, but some of them may begin to show some early signs of either social withdrawal or in sort of late middle school, but others may be completely normal right up until the time that they become sick. We have many stories that, the people would say, well, my son was a star basketball player, a good student, everything was going well, and it can happen relatively, certainly in the context of relatively normal childhood. However, there is a period prior to the onset of psychosis, what we retrospectively call prodromal period, and that's where a lot of the work is currently happening, what we call finding people who are at clinically high risk, and that if we do find them, I'd be happy to spend a few extra minutes later on, we are able to reduce their normally, if you find people who have subthreshold symptoms, who do not yet have a psychosis, they have subthreshold, they may have a feeling, they get on the bus, they think somebody's watching them, they say, no, this can't be true, and they dismiss it. Then it happens again. Or they may hear their name being called, but they know that there's nobody around. So this is not psychosis. However, if you identify these people, if they're having other difficulties, like mood changes, anxiety, and this is what we call clinical high risk, and we run a clinic for this, the conversion rates normally from that state to a full-fledged psychosis are about 30%, which is quite high. However, with interventions, that's non-medication interventions, psychotherapy, family intervention, CBT, we have been able to reduce the conversion rates from 30% to about 10%. So it is possible to intervene very early on. The question is, how do you educate people that, it's a very subtle sort of thing. How do you ask people that you should be seeking help if you have such and such symptom? However, after the first onset of psychosis, the first episode generally, and I'll say a bit more about that, is relatively easy to treat as far as symptoms are concerned. And I'll show you in a minute. The problem then is the relapses that happen that basically start a downward trajectory. So I mentioned this earlier already, that the incidence this is on the island of Montreal, for schizophrenia spectrum psychosis is higher. It's not higher than many other places, but it's higher than what we had believed before. And it's particularly, as you can see at the bottom, it says, if you take the quarter that has the worst material deprivation, they have a 68% higher incidence. And if you take people with the worst social deprivation, they have a 77% higher risk of developing psychosis. Which brings me then to try and how do we understand, why do people develop a psychotic disorder? We don't know one cause. And people, even our colleagues would say, well, that's the trouble with psychiatry. You don't know what causes it. I would say that's the trouble with all of medicine. There is not a single modern disorder that we know this is caused. Diabetes, do we know what causes? No, we know there are risk factors, genetics, obesity, smoking, all of these. We know risk factors, and that's exactly the case with psychiatric disorders. We know risk factors. And how does that work? That if you have certain risk factors, in other words, you have a higher vulnerability, and you are exposed to high levels of stress. So you see the part where, the shaded part, so you have high levels of vulnerability, and you have high levels of stress, you will become ill. If you have low levels of vulnerability but extremely high levels of stress, let's think of the example would be, obviously this is more historical, people who were in concentration camps. There can't be a bigger stress than that. Apart from the starvation, people did become psychotic there under pressure. Or if you deprive anybody sleep, these torture victims, often they'll develop psychotic symptoms. So it is a combination of how much vulnerability are you born with, how much vulnerability you develop over time, and how much stress are you exposed to at any given time. One of the reasons we see often an onset of psychosis at 17, 18, 19, especially when people go to university. Around September, October, we see a number of cases because it is a very high level of stress. We have one of our sites in the youth mental health is all first-year students at University of Alberta, 8,000 students, because 20% of them come from very small remote communities, 20% are foreign students, so they have no family, and they are in a new environment. We consider them as being at relatively high risk. So what are the risk factors? Genetics, yes, definitely is a risk factor. If you have a family history, you have a higher risk, about 10% risk as opposed to 2%. And that would be if you have a first-degree relative. And if you have an identical twin, which is as close as you can get to having identical genetic material, you do not have a 100% risk. You have about a 40 to 45% risk. What that means is that genetics, that the inherited genetics is not enough to create a psychotic disorder. You need something else in the environment. Only 15% of cases of psychosis that we would see in a population would actually have a family history. So vast majority of people who develop a psychotic disorder do not develop it because they have a family history. So there have to be other causes. We all carry genes that are potentially, if they get together, those genes, and given the right or the wrong environment, are potentially make us liable or vulnerable to psychosis. So this is why it's not possible to predict who is going to develop psychosis, who is not. Any one of our children are potentially vulnerable. These are the risk factors that now we know. Heavy drug use, especially before the age of 16, cannabis, because cannabis is the most common drug used before the age of 16. Especially, it's about 20% of the population is genetically more vulnerable to effect of cannabis when the brain is still developing, and brain is still developing up until the age of 21. Birth complications, if there have been obstetric complications like lack of oxygen to the brain at the time, it increases the risk by about 2.5 times, whereas cannabis use before the age of 16 increases the risk by about 4 times. Migration, moving from one country to another, increases your risk, and especially if you are a visible minority and you move into an area, and this is particularly, a lot of this work was done with people who came from Africa and the Caribbean, black Caribbean population in Britain, or the people from Suriname into Netherlands, and the effect persists in the second generation. So second generation who are born in the host country have as high a risk as their parents did when they were younger. And it's much higher risk than the same group of people would have in their parent country. So it's the migration itself and what else goes with the migration. Growing up in a large city increases your risk. We don't know exactly why, whether it's purely environmental in terms of stress or so on, whether it is environmental in terms of viruses and living in very close proximity to each other. Childhood abuse, childhood trauma has been clearly associated with, and head trauma during childhood increases very small increase in risk. So these are the risk factors, but as you can see, there's no way telling that even with if the risk is 4 times, it still is only about 8%. So we have no way of knowing who is going to develop. We just have to keep in mind that these are potentially targets for public health. The treatment, what is the full package? You notice that when often people talk about treatment of psychotics, they say antipsychotic medication. It is important. It's actually essential in 90% of the cases, but it's not sufficient by itself by any means. And taking medication or persuading people to take medication is the hardest part. I often say to my students that pharmacology, psychopharmacology, which is what we call this field, the pharmacology part is the easy part. It's the psychological part that is very, very hard to persuade a 19-year-old to take medication that may have side effects, and then also to tell them, which in my opinion is wrong, to tell them you're going to need this for the rest of your life. It will scare anybody. And it's not unusual, it should not be unexpected that the person would refuse to take medication. So the art really is that we have to practice is how do we persuade someone to take medication and make it as one small but important means to getting somewhere else. Case management, where a person has an allocated case manager who works with them very intensively. Education, family interventions are, if I had $100 to treat a patient, I would spend $50 on medication, and if the rest I could only buy family intervention, that's what I would buy with the rest, 50%. Why? Because family intervention, if it's done properly, will reduce your relapse rates by about 50%. And that is because it's not a rocket science. It's very simple that families, I don't have to tell you this because I'm sure some of you may know this already, families suffer as much as the person who has the illness, but also there is a great deal of tension gets created. You're stressed, and when you're stressed, you don't always respond the best possible way. And sometimes, especially with psychotic disorders, the best response may not necessarily be the most natural response. The most natural response may sometimes be you sit with the person and make them listen to reason that this is not true. Nobody's going to hurt you, it's all in your head, because that's not going to work. What's going to work is, yes, we understand you're under a lot of stress. What you are feeling is really, we believe you, everything is happening, and just calming the situation down. And when families know that, they practice that. They actually do it, and family interventions are all designed to reduce the stress in the family, inform the family about the facts of what is real, what is not, and then support them and give them help in how to reorganize maybe certain types of communications, how to react to a patient when they're acutely ill, and how to push the patient a little bit at a time so they begin to regain some of their functioning. There are many other aspects of treatment that are really important, but most of the time not available. Family intervention there's at least 25 randomized controlled trials showing that family intervention it works. Same with CBT. But do you know what percentage of patients and families actually get family intervention? Guess. It's about 17% is the figure, but that's nothing when you could really, really have a huge impact. And why might that be? There's nobody selling family intervention. People are selling drugs. There's pharmaceutical companies make sure that the drugs are on the market, and doctors can prescribe them. They have to prescribe them because it's an essential part of the treatment. But nobody is going around and saying, look, family intervention works, so you better do it. We have guidelines. The best guidelines are probably the British guidelines, what are called the NICE guidelines, National Institute guidelines, clearly states that treatment of schizophrenia or psychotic disorder consists of antipsychotic medication, family intervention, CBT. So in Britain, you're actually obliged to provide this. I'm not saying they all get it, but if people demand it, they have the right to demand that where is my family intervention, where is my CBT? Okay, talked a little bit about psychosis, and I'm just going to touch upon a few challenges of treating psychotic disorders, and also give you a sense that there is actually a lot of hope. But I also hope that you, as friends of mentally ill and people with mental health problems, take upon yourself to really advocate, because there is a lot known that often the public doesn't know, so they don't know what to ask for. So I'm going to try and give you a little bit of a flavor of what we're actually planning to write guidelines, not for doctors, but for the public, of what is there that is available, that works, and why you should check, is it available to you or is it not available to you. If we follow people after they have first onset of psychosis, this is roughly what happens. 1/3 of them will have multiple episodes, but in between they're relatively well, not completely well, but relatively well. Another third will have multiple episodes, but with each episode they deteriorate. They respond less to treatment, they have more negative symptoms, they can't go back to work, and so on. About 16% only have one episode. The problem is, and we are trying to look at this, we've been working for the last 12, 13 years to identify what are those indicators that might tell us that who might only have one episode. Because if we know that, then we would only treat that person maybe for a couple of years, and then start withdrawing the medication, so they are not unnecessarily exposed to medication they don't need. But right now we don't have that science. And a small percentage, 7%, don't even respond to treatment in the first episode, so they don't really recover completely. But that's only 7%. 90% of people will show some recovery if they get the right treatment. here is some figures from a few years ago that keep in mind, these are data from the United States, which is not the best country to have treatment for psychiatric illness. 82% of these people with first episode psychosis will have a relapse in the first 5 years. You notice one thing, that the relapse rate in the first year is only 16%, and then it jumps to 53%. The reason for that was that this study, like most studies in the United States, are well funded, and patients come into the study because they can get treatment. So they were followed very closely for 1 year. After that, they were let go because the study was finished, but they followed them. And as soon as they were let go and you go and seek your own treatment, whatever little treatment there is available in the community, this is what happens. I don't have a figure to show you, but in our early intervention program, our 2-year relapse rates are about 27%. So this is about half, because people are followed very, very closely and they receive intensive treatment. And this is how high the remission meaning a total absence of symptoms, or minimal symptoms with no effect on functioning. 80% of people will get into total remission of positive symptoms in an early intervention program. That's a combination of medication, case management, CBT if you need it, and family intervention. The problem is that many patients, or majority of patients, will respond to treatment. But if you then include, when we treat them, yes, positive symptoms go away, but negative symptoms are much more resistant to treatment. So if you include positive and negative symptoms and what we call complete remission, only about half will get into a complete remission. Now, why might that be important? Because negative symptoms actually drive a lot of the functional outcome. And even a smaller percentage recover. What do we mean by recover? Recovery meaning that they are working, or they're going back to school, they have social relationships, they are living independently, and that's sort of the overall definition of recovery. When we ask patients, what does recovery mean to you? You know, up until now, we've always sort of had the doctors and social workers defining what recovery is. But when you ask patients, basically, let me explain this a bit. Most patients do not think of recovery as one-dimensional. They want recovery usually on 2 or 3 dimensions. Majority of them consider themselves recovered if they're relatively free of symptoms, if they feel psychologically well, which is different from being free of symptoms, and if they are socially well. In other words, they have social relationships, they have a job, they are going back to school, but all 3 together. Very few patients say, I'm recovered as soon as the symptoms are gone. Whereas the treatment system thinks they've done their job. The symptoms are gone, you discharge, go and see somebody, and you'll be fine, or you will not be fine. But we haven't traditionally thought about, well, what about your physical health? What about your psychological health? Are you working? Do you have and that takes a lot more work and a lot more effort and a lot more than just the healthcare system. I won't dwell on this, but this is something we're developing as a model for what does it mean for a treatment to be effective, and how does a person go from developing psychosis all the way down to be functionally recovered. And there are multiple steps, and I don't have the time to go through the detail, but we want to look at from the time the psychosis develops to next step is you go seek help. Now, how do you know when to seek help? And for that, we need to increase mental health literacy of the public, so that the public becomes aware that if you see this and this, it's not some adolescent crisis. It's not, people will say, well, adolescents often don't want to talk to their parents. That's perfectly normal. But when they stop talking to their friends, that's more worrisome. If they're withdrawing from everything, something is going on that's more than just an adolescent crisis. And then the next step is they seek help, then they should know what kind of help should they be getting. And very few people know what they need and what they deserve. And And then you are entering a system, you go to guichet d'accès, you become a piece of paper because somebody takes your information. They say, we'll contact you. That may take 4. We've done this analysis in a number of jurisdictions. It's the same phenomenon. Then they have a meeting, then they'll pass you on to somebody else. 4 to 6 weeks might pass, but then you might see somebody. That's not a way to run a system. You should be able to see somebody when you go. And this is what this new youth mental health project that we have, under this, when we opened the center in Dorval-Lachine in November of this year, you will have access in 72 hours. That's the maximum. That not access in terms of take somebody filling a form, but seeing a clinician, not a doctor, but a trained mental health worker who can assess, is the problem serious? Is it something that needs to be attended to right away, or is it something that is just a passing crisis, or do we need to get rest of the system involved? And all the way to the point that, yes, you do see a psychiatrist, you get into treatment, and then the issue is how to persuade people to take medication, how to keep them on treatment, what other treatments are needed, and then attention to physical health has generally been ignored. People with schizophrenia die 25 years earlier than the general population. That shouldn't be the case. The rest of the population life expectancy has gone up like this. If you look at people with mental illness, especially with psychotic disorders, it's flat or it has gone down. And that, I think, is a moral failure, in my opinion. The desired outcome in treatment should not be just getting rid of symptoms, it should be getting back to functioning. And if we ask patients, I always like to give this example because I think it kind of expresses a number of things. I had this patient when I was working in London, Ontario, and ran an early intervention program. He would refuse to take medication. He was born in Canada, but Somalian parents. He was about 18, so I said to him, why don't you take treatment? Things would get better. He said, what would get better? He said, nothing is wrong with me. And I said, well, you're not able to go to school, and what do you want to achieve? He said, I want to get married, So I said, so okay, let's sit down and figure out, how do people get married? How do you get to that point to get married? And then we went through the steps. You'd have to finish high school, you have to get a job, you have to, you have to be a viable person to. And I said, in the process, you might need something. We didn't talk about diagnosis. You might need something to control the stress that keeps you awake at night, that, you're not able to attend school because you have no concentration. So why don't we just try a little bit of medication that would help you with that? And after 3 months, he agreed. But only because I think we put the whole thing in some perspective for what was important to him. But that's not often the discussion that takes place. So let me tell you now, if functioning, for me, for my colleagues, for the whole early intervention field, the ultimate goal is getting people functioning again. And it's not only for the person, for the society as well. This is a health economic issue. The loss to the society is huge. It's billions of dollars. And we have very low employment rates for people who even recover from psychosis. We're doing a study, currently we've been doing this for the past many years. We have 2 more years to go, comparing outcome, first episode in Montreal, outcome in Chennai, which is a city in South India, used to be called Madras, using identical instruments with the same, similar treatment. Their employment rates after the psychosis clears up are about 67%. Here, 28%. Now, there are many reasons for that, but one of the reasons is that their employment happens more informally. But because there is no state doesn't provide anything, so people are mobilized. And when we do focus groups, in both places we've done focus groups, patients there say, well, the family has done a lot for me. They're exhausted. I need to do something myself. When we talk to patients here, when we talk to families here, they say identical to what people in India, families in India say, that we want to help. But when we talk to young patients, they say, I've had a lot of help from my family. I want them off my back now. But those are, cultural differences. But I think there may be something that we can create in the middle somewhere where perhaps there's a little bit more help. And also for a 19-year-old, and one of the reasons we refuse to sign disability for a first episode patient, because we think they can go back to work, we'll sign them for temporary, but not that permanent disability. Because for a 19-year-old, getting $850 may seem a lot, but it's nothing. When they have the potential to go back to school, to finish school, and maybe get a job. So functioning at the end is extremely important. And what drives functioning, when you look at from a research perspective, a few things particularly. Delay in treatment at the beginning is a fairly strong determinant of how well a person is going to do, both clinically and functionally. So the longer the delay, the less likely the person will do well. Environmental stress, particularly interpersonal stress. How the person was functioning prior to getting sick, obviously that would. But the most important one is after they are treated, how long do they stay relatively free of symptoms? Which means that how long can treatment be sustained and the person be kept well? Because if you're only well for 2 months, you don't have time to pick up and go back to school and finish or go back to work. But if you're well for 8 months, you have enough time to pull together all of the resources and cognition. And here the verbal memory is the one that's extremely important. If you have poor verbal memory, you are going to have more struggles in functioning well. Okay. I'm going to skip some of this. How are we doing with time? Yeah? Okay.
It's interesting enough.
Okay. Let me show you some data, if you like data. This is a study that we'd done in my previous program in London. As I mentioned to you earlier, most patients will get rid of their symptoms if they're treated adequately. And here we have a population of 150 first episode young patients. 84% of them reached complete remission of positive symptoms, psychotic symptoms, and 56% reached remission of all symptoms, positive, negative. Now, you would think that these 56% would be now well enough to go to work and to function well, but when we look at it, it's at the end of 2 years, less than half of them actually managed to function well, even though they were free of symptoms. And no one who did not get rid of their symptoms was functioning well. But the important thing is, why would only less than half get to better functioning? And there are several reasons. One of the reasons that has been relatively undiscovered or unattended to until very recently is people, after they recover from an onset of psychosis, often develop social phobias. They become very anxious about leaving house. They no longer have psychotic symptoms. They're not leaving home because they think somebody is going to harm them. They just don't feel they can face people. And a lot of it has to do with self-stigmatization, that they think they have, what will they tell their friends? How will they deal with different social situations? We tell them, look, it's not good for you to smoke marijuana. If they go back to their social circle, what will they say? Why I don't want to smoke? I mean, these are real issues for young people. And these are some of the reasons. And also, of course, the availability of employment, stigma in the social sphere, but also there is a lot of self-stigma and stigma that we as the treatment system introduce. And let me give you an example of that. If we say to a 19-year-old, and it's not an unusual, this is what happens in most regular care, look, you have a very serious illness, It's called schizophrenia, and as soon as that word is heard, the young person thinks about all the movies they have seen and all that goes with it. And now you have to take treatment, and you're going to stay on this treatment for the rest of your life. We don't know whether you'll be able to go back to school or not. And that's a pretty hopeless situation. So what would be a better way would be, look, I think we are going through a real crisis. We know that it's fairly serious, but it's totally treatable. We will work together. We want to get you well enough that you can start, looking at things. And if they don't want to hear diagnosis, what is the point of throwing the term schizophrenia at them? We actually, in our program, do not use the term schizophrenia except for research purposes when we have to report, because nobody will accept our papers if we don't actually use it. But with direct dialogue with patients, we just say to them, this is a serious mental health problem. And then when they are well enough, they want to sit down, we show them the picture of the brain, we show them what might be going on in the brain, but we also all the time tell them this is not a hopeless situation. People get out of this. And in fact, I have a PhD student right now whose entire PhD is on how people can actually grow into better human beings after having an experience with serious mental illness. And there are many, many cases where we have cases where people say to us afterwards, I am so much closer to my family now. I didn't appreciate many things before. Now that I have gone through this, I have a very different perspective about life. I want to help others. We have recently acquired a PhD student who actually had been a patient in our program. And he decided to do his PhD combining, he's doing a PhD in business management, but combining business management with aspects of mental health. And a lot of that has to do with resilience and taking people's, everybody has strengths. Just because you have a psychotic disorder doesn't mean you don't have all those strengths that you bring into it. So to avoid self-stigma, we have to give people, as soon as they're well enough, try to remind them they actually have an identity other than psychosis. We used to run a group a number of years ago where we would make people talk about themselves, but they were not allowed to talk about their psychosis. This is after their symptoms were gone. And sometimes people say, I don't know what to talk about. And I'd say, well, you have very nice hair. I think everybody observes you have nice hair. Why don't you tell us something, how many compliments have you had about you? And that gets you into a conversation that has nothing to do with psychosis, because people have to lead their lives. So this is a very different way of looking at mental illness. But I and many of my colleagues in the early intervention feel that it's necessary for us to make that philosophical shift. Here's another study which we did here in Montreal, where we found again the same thing. The longer people are symptom-free, the more likely they are going to get into work. Okay. Now, last few words on early intervention. What is early intervention? For Dorval, what is your hospital? What is, like if somebody got sick here with psychosis, where would you go? Lakeshore? Okay. Although we do occasionally get people from Dorval in our PEP. Don't tell the administrator I said this, but I think you should be demanding an early intervention service. Every place should have an early intervention service. Ontario, when I was there for 20 years. I left in 2002, but for 4 or 5 years before that, a few of us got together, about 4 programs, and we started putting pressure on the ministry. And we realized that this is not going to work very quickly. And we had a very, very good family organization in London. So we took them along. It took 3 years, but finally Ontario did create a policy for early intervention. And they just had their, was it 15-year anniversary? Yeah. Last year, and they invited me to give a talk, and I was totally blown over. They have 55 early intervention programs now in Ontario. Every jurisdiction has one. What is early intervention? Early intervention is basically identifying people with psychosis early so that they don't suffer this delay, because what the delay will cause may be relatively harder to manage later on. And when you identify early, but you also have to get it right. Get it right in the sense that there's no point identifying someone with psychosis and then giving them the same old terrible treatment, which is just medication and go home. So the second part of early intervention is a specialized, comprehensive, evidence-informed, compassionate care. This is how I would define it. It has to be done within a philosophical framework that you don't treat mental illness as any different from anything else. You have qualified people who can deliver CBT, who can deliver case management, who can deliver family intervention, which is actually out of all of those, is the cheapest one. You can train people in 3 days to give excellent family intervention, clinicians, social workers, nurses. We have at least 6 people. We have got them trained through one of our colleagues in Maine. And then these early intervention programs are generally strength-based, that we don't only rely on diagnosis, we rely on people's strength, family strength, and the idea is that it should be oriented towards recovery, not towards just treatment. And this is what it kind of looks like. This is our model that we operate in PEP that I started in 2003 and had operated for 7 years before that in London. So you start at the left upper corner. The person calls. We have an open referral system. You do not need a doctor's referral, and there should not be any need for anybody can call, family, and they get seen within 72 hours, or at least we offer to see them. Sometimes people don't come in 72 hours. Most of the time they do. Unfortunately, many still come through the emergency. But we have a relationship with the emergency that as soon as they see somebody, they call us, we send someone, and we have one full-time clinician whose entire job is to do that initial assessment. And that's what they're trained to do. And after that, if they meet the criteria for psychosis, then they get admitted to the program. If they need hospitalization, they get admitted to the hospital. Only about 50% of our patients actually have to go to the hospital. And then they have intensive case management. For the first 3 months, they get seen 2 to 3 times a week by the case manager and by their psychiatrist once a week for a month, every 2 weeks for another 2 months, and then at least once a month by the psychiatrist. And then we start introducing other treatments as they start feeling better. If they need CBT, which is roughly about 35-40% of cases, we give them CBT, but everybody has case management. And we have our case managers usually have a maximum caseload of 20, so that they have enough time to spend with the family and they don't always see their patients in their offices, preferably not, and meet them wherever they can. Okay, I think we covered this. Now, how do you do early case identification? It's very complex. If you have a small community, let's say of 20,000 people, it's relatively easy. You can go basically door to door. You can send information to every household. But in large urban centers, it's not possible. So your best bet is to work with all potential sources of referral. But the program has to have an open door policy. You cannot say, so you don't have the right kind of referral. We only take referrals from doctors. Because if you have a system that is centered around physicians, I'm a physician, it's not anything I have against physicians, but I don't think we can run a mental health system that revolves around physicians only. You do not need to see a psychiatrist every time you have a mental health problem, but you have a system where a psychiatrist is available as soon as they're needed. You will at least get care very quickly because, for example, in our program, there is a trained mental health worker who will see you within 72 hours. She has access to a psychiatrist immediately. If she thinks the person needs to be seen tomorrow, we have 4 psychiatrists who allocate half a day, so we have pretty well every day covered, that they'll be able to see the person next day or the day after, or if it's an emergency, the same day. But at least the person is not waiting on some waiting list somewhere and to hear from a psychiatrist 6 weeks later. By that time, the person is already in hospital most of the time. So I think there have been several early case identification programs. We did one here in Montreal, in our catchment area. We went to every school, every college, counseling center, churches, CLSCs, and essentially, basically, to educate them and also to say to them, call us. We don't have any forms, because I think filling forms is a way of obstructing care. What's wrong with the phone? You just pick up the phone and we showed them who's the person they would call, they would talk to, so that it becomes a much more of a, and you can also from our end, we can sort out things on the phone. We say, no, this doesn't sound really like psychosis at all. I think you're better off. And when we did this early case identification program, we got lot more referrals than before. But most of our referrals did not have psychosis. But we had a moral responsibility, because once we saw them, we had to arrange care for them. So they actually got very quick care. And in fact, that's where I got thinking that having a service just for psychosis and early intervention for psychosis is not good enough. We need an early intervention service for all mental disorders. And that's when we got into this. We applied for this youth mental health grant. It's a big grant. It's $25 million over 5 years. And that's what really we hope to do, is that in 12 centers, if we can show an early intervention model works for youth with mental health problems, and then hopefully it will get scaled up in other places as well. So just to conclude, as far as psychotic disorders are concerned, they are serious problems. They affect our youth, but they are almost entirely treatable. Not everybody recovers completely, but vast majority of people can get better. One of the other results from early intervention programs across the world has been a significant reduction in suicide. We've been in operation in PEP Montreal for 13 years. We have had actually 2 deaths. One was clearly a suicide. We would have expected 5%. We've treated about 730 patients so far. And I talked to my colleagues in Melbourne. They have a much larger program. They cover the same story. But their story is a little bit sad, because they stop after 18 months, and they have discovered recently that after their patients were discharged, their suicide rates actually went back to where they would have been. So we actually probably need to treat them for much longer than 18 months. Early intervention services provide significantly better outcome. I know I didn't show you the data, but I'd be happy to share with you. But it's also more humane. If you read the testimonials and surveys from families and patients, that's what they describe, that it's more humane than what they had experienced before. Recovery is possible, and as I said, it's even possible to have growth beyond psychosis, a personal growth. We believe that AI services should be a policy of every mental health, every government. And now we have several provinces, BC, Nova Scotia, Ontario, and Yukon have a mental health policy on early intervention, and they have early intervention programs all across the provinces. Quebec does not. And families and service users are the most, in my opinion, the most important agents of change. So if there's any message I have for you, or even a request, I really think getting involved in youth mental health, in making a voice and letting the politicians hear, because if we go to them on our own, they see us as we're self-serving, that we just want to build bigger services, bigger research programs. But if you go, and if parents go, if the youth go, and this is a big part of the Youth Mental Health Project, is that it's very much youth and family driven. We have a budget set aside for family council every year, $50,000. We have a budget set for youth council, and they do their own things, obviously within the Access Open Mind framework, but they are driving it. So when we go to politicians, they come with us because it has much more of an impact. So I'm going to stop there, and I hope that if nothing else, I've conveyed some hope. I'll be happy to answer any questions if you have.
Yes.
Dr. Malla, you mentioned that
I'm sorry, just for the purposes of their witness.
Sorry?
Okay, now we got it working. I'll just give this to you.
You mentioned that even a 3-day training for a family, from the viewpoint of family intervention, would be sufficient most of the time. Where would such training be available?
Because I was talking about training for clinicians. So, for example, if I'm running a clinical program, it's not going to cost me a lot to train 3 or 4 people, send them for 3 days. In Portland, Maine, and in fact, a few years ago, we had enough clinicians in the hospital who wanted to be trained, so we brought the trainers here. It was much cheaper. Instead of spending $2,000 on each trainee, 20 trainers, that's $60,000. Spend $15,000 and bring the trainers here. So you have to be a clinician, like a social worker, nurse, psychologist, to have some, obviously some clinical skills. And then this is the extra training to run a multiple family group.
But the family intervention, would it not require the family to have some idea as to, how to do it, and what are the beneficial ways of,
Yes, that is the whole idea, that this particular intervention, actually all family intervention, but this particular one that I'm talking about is called group family intervention. What you do is you have a trained therapist, 2 trained therapists. You bring maybe 6 parents and their son, daughter, whatever. So it's a fairly large group. And you look at each family brings a problem that they are facing, okay? And the therapists don't provide the solutions. You bring the solutions out of the family members. So after about a year of doing that, then the family does it on their own. You don't need the therapist. So in a sense, each family is getting trained then, and they often will then start their own groups. For example, at PEP, we have a family support group. Some of those family members would have gone through our family group therapy. I prefer not to call it therapy because it's family group intervention. So they would have learned some of the ways of how to, and there's no better help than helping each other. So that's the whole idea. So it's actually economically, it makes the most sense. Some families don't like being in a group. Then we provide individual family intervention. So each therapist would meet with their family. Each family has different issues, and you would basically deal with those issues. The important thing is that families have to have the right kind of education about the illness. They have to have hope. And they have to know ways of reducing the tension, reducing the stress.
Now, I know that Douglas holds those sessions for families where there is a patient, but Douglas is a bit too far for most people.
I know, that's why I'm saying, I think every jurisdiction should demand,
there should be one in Dorval.
You should be going to the Lakeshore Hospital and knocking on the door of the CEO and asking why you don't have an early intervention service. Just don't tell them I told you that.
Any more questions?
Thank you. Hi, my name is Emmanuel. I work at Friends for Mental Health. Thank you very much for the conference. It was very interesting. My question was, maybe I'm misunderstanding what's the concept of early intervention, but I was wondering if you also provide services for older people that haven't been diagnosed or that haven't have intervention before. So do you have such things as late or later?
Late onset?
Yeah.
No, it's first of all, late onset is late onset schizophrenia. If you're talking about in the 50s and 60s, when people are in their 50s, it's a very, very different problem altogether. Because first of all, if it is recognized, it's relatively easier to treat because if you think about it, people have had a whole lifetime of building their skills, having families, having led a life, and it becomes, in my opinion, a bit more of a pure medical problem that you treat the psychosis, whereas for a young person at 19 and 20, they have a whole life ahead of them. It can either get derailed or it can be propped up for a while in order to so we've concentrated on the first onset, which is up to age 35. But as I said earlier, we also do see people who are regarded as being at high risk, not yet developed psychosis, and that's really a new field.
Fiona.
Yes.
Thank you. Could you tell me what physical symptoms occur during psychosis?
There are no physical symptoms of psychosis, but people who have psychosis generally get into poor physical health, partly because either nutritional reasons or they will start smoking, because smoking does actually reduce your psychotic symptoms a little bit. It'll calm things down, or because they have become so inactive, they gain weight. So there are no direct symptoms that could be related to psychosis. They are sort of indirectly related to psychosis, but they are the physical health problems. And then some medications will add on to that because most medications cause weight gain.
What about like a symptom of pinching for the skin, like a feeling?
Well, that's a perceptual problem. That's a physical experience, but we would not medically call it a physical symptom. It's a matter of really what you call it, but it's an experience which we would regard as it's a perceptual problem.
Okay.
That person is perceiving that somebody is pinching them when no one is actually pinching them. Yeah.
I see.
So that's an experience, a perceptual experience in the somatic, in the physical sense. You can have people sometimes saying, I feel bugs crawling. It's very rare. It sometimes happens, especially if people have been into cocaine or some other hard drugs.
Thank you.
I have a quick question. You talked about remission, and when someone is in remission, if they maintain, are they medicated for life, or does medication stop and then just a follow up? Or
in the first 5 years, it's very difficult for people to completely get off medication. There's no really hard and fast rule when you get off medication. Most people will try without it. Okay. Would we advise people to try without it? No, but what we would do is work with the person and say, okay, let's keep reducing it instead of suddenly stopping it. And if things are going well, we'll try without it. But then it becomes even more important that the person be seen regularly, so that if there are very early signs of relapse you can pick up once you get to know a person. But it's really a lot of it is to do with an agreement, because the young person has to have a say in his or her treatment. Very few people, if I were 19, would I say, yeah, I'll take medication for the next 5 years? There's no way. At that age, you expect yourself to be healthy and strong, and so it becomes really, we go from month to 3 months to 6 months if things are going really, really well. In fact, we published a paper a few years ago showing that 1/5, 22% of our patients get better very fast within the first 6 weeks. But they also are at very high risk of stopping medication because understandably they say, there's nothing that seriously wrong with you. Look how quickly I got better. But because we follow them for 2 years, so we then pick up that after a while, some of them, in fact quite a few of them, will start showing signs of relapse that they can get back on the medication. But some won't. But we have no way of knowing, who those people are, and we're sort of trying to work on that. And paradoxically, if a person has no other risk factor except drug use, and they stop drugs, they take treatment for a year or so, but stay off the drugs, it's quite likely they may not have another relapse.
Are the adverse effects of the medications a consideration for the young people?
I think they are. Of course, they are. Weight gain is the main one, and we just have. I think we have to do our best to manage that. We try our best to get patients to engage in physical activity. Like we have an arrangement with a couple of the YMCA's that they give us a reduced rate of membership. So the patient only pays $5. We pay from the program $10 because we think in the long run it's actually a good investment to get them engaged in physical activity. But there is hardly any medication without adverse effects.
Yes. I think we had a question here. Yeah.
Oh,
go ahead.
Thanks. I work at a community. I work in the community. I'm a community worker for Community Perspective. One of the things that we find is it's really difficult to reach the younger population. For physical activity, we do have a floor hockey program with another organization, and that works. But it's really hard to get the younger population involved in a community program or even a day center, because they go into a day center, they see older people who are living with different types of mental illness, and it scares them.
Mm-hmm.
So what can we, until we get something here on the West Island, what can we, as different organizations of the West Island, what can we do in the process to be able to service the younger population?
Get them engaged somehow. It's interesting. When I was driving, I was asking, there were 2 young people, they're probably teenagers. I said, where is the community center? They looked at each other. they said, oh, I think it's probably that way. They did redirect me properly. But, this is the whole idea of designating, our idea of this youth mental health centers are essentially, these will be like one-stop shop where a young person between the age of 11 to 25 can walk in or be brought by somebody, and it will be a very youth-friendly place. These places will actually be designed and decorated by young people. There's a similar place that's opened already on Granville Street in Vancouver. But that's what we're aiming for. Initially, we may start at a temporary space, perhaps in Lachine, but Dorval, La Salle, Lachine, as you know, are one C3S, or what used to be C3S. So our plan is to eventually have a one-stop shop. What I would suggest to you is, as many of you can, join our family council and get involved and shape what's going to take place in Dorval, La Salle, Lachine, because that is your local community, and these youth mental health centers will have not only psychiatric services available, they will also have addiction, they will have employment services. Eventually, we want to bring physical health care, sexual counseling against STD, all of this, all grouped under one, so that it's youth-focused rather than mental health focused or physical health focused. So it's focused around problems faced by youth.
Are you looking at Pierre phone, or are you just staying in this area? Because there's Pierre phone, which is part of the.
Just for the webcast, please give me the
Oh,
microphone.
sorry. Are you looking at Pierre phone also because there's a huge population of
Not
individuals?
right now, because what we have right now is essentially a research project that's funded by CIHR, which is Canadian Institute of Health Research, and Graham Beck Foundation. Each have contributed 12.5 million, and we have 12 sites across the country. In Montreal, we've taken two. This set throws us here, Dorval Saint Lachine, and we've taken. It's actually one of our biggest sites. And we've taken CLSC Park Extension as an example of, Dorval Saint Lachine is an example of sort of urban, suburban, mixed English-French population. CLSC Park Extension is a high immigrant, it's probably one of the highest immigrant population. And then we have Repage, which is a mixture of services downtown for homeless youth. So these are our three Montreal sites. Then we have Mistassini, the Indian Cree Nation. Then we have Puey, that is in Nunavut. Then we have New Brunswick sites. We have First Nations in Saskatchewan. We have Central Edmonton, University of Alberta. So right now we basically have to first show that we can do this in these sites, get good outcomes. In the meantime, we're talking to provincial governments to get ready for scaling it up. So it's quite possible that in a few years, in another couple of years, there might be a call for 4 or 5 more communities, but then the communities will have to apply, get together, because that's the whole idea, pull the community. Chatham-Kent in Ontario is a great example. We just launched their site. It's the first site we've actually launched. I was there on May 9th for their launch. I've never seen so much community involvement. Everybody was there. All the services were there. The young people, age 11 to 25, they had produced music shows, dance. They created a song called Respect Revolution, and it's basically that we have to respect everybody, whether they have physical problem, mental health problem. So it really mobilizes communities. And I think this is the only way to make mental health acceptable, to take it out of this sort of mystery that it is currently, and also to put pressure on governments.
I have a question that's come in online.
Yeah, okay.
Okay.
Yeah, sure.
I'll just read this first. We also have a question. We were in the PEP program at the Allen for 2 years, and that just ended. We didn't receive a family support group at all. Can we still be eligible for the PEP program at the Douglas? Our son did have a second episode 6 months ago. Thank you.
My suggestion would be, well, first of all, the young person would not be able to go from one program to another, but there is nothing to stop the families contacting the family support group. I think they would be open. Yeah.
Thank you.
Hi, I'm from Friends too, and I'm thinking about the families that are here may have already had experience getting their loved one to the hospital, but maybe the people that are listening online, do you have a few words to say how you'd actually get a loved one to the hospital? I spend a lot of time helping people figure that out, so I'm interested in what you would say.
How you would get them to hospital?
Yeah, once they're there, that's great, but how to convince a young person to go?
Well, first of all, I think one assumes that we've got to a stage where they have to go to hospital.
Not have to by court order.
Well, I think there are layers of, obviously the court order is the extreme, but if you had an early intervention service you would not need to take them to the emergency. You would contact the service. and go there to not take them to the hospital emergency, but to go and take them to that clinic, and somebody would see them there. So you kind of, in a sense, bypass the hospital. However, I know that there are situations when people completely refuse, and if it is a dangerous situation, you have no other option but to bring a court order. Even then, it is possible to have a slightly softer landing, which is that if you still have we have had situations where families are desperate, they don't know what to do. We would see the families, but the patient refuses to be seen. So we support them, and then we would say to them, I think you have no option. However, when you do that, let us know, so we'll meet the person in the emergency, and they have a somewhat of a softer line. They are not strangers there. And then we would advocate for them and hopefully bring them directly into our own unit, because we have dedicated 6 or 8 beds at the Douglas just for first episode patients. So it is not the best way to enter the system, and I think one of the ways to hopefully reduce it over time is to go through the early identification and bring people for an assessment or seek an assessment, even when there maybe it's not for sure it's a psychosis. And that's when we have to get over the stigma of being seen for some mental health problem. And one of the other reasons we think a generic youth mental health approach may be better, because you don't have to know what is the nature of your mental health problem. You have the same place to go. It's a one place where you'll get all of the services, or at least be connected to the right service. Thank you.
I'll just say a couple words. I just want to thank Dr. Malla. I think it's not only is he brilliant, but obviously his heart is open to all the people he works with all the time, and he has a tremendous amount of compassion. And for that, we're extremely grateful. I have a small gift for him.
Thank you.